It's very nice to be here. Well, actually, and I think it will be Frederick, asked me to tell something about quality of life. And I thought it was quite challenging because quality of life I'm not an expert in. And when you look at the next slide, I think the quality of life is even better in the Nordic countries. So why should someone from the Netherlands talk about quality of life? But there was a glimpse of hope when I looked further, because when here you find the Netherlands, and here is Norway. So I can be of added value. And when I found this, I decided to talk about quality of life, which was the original topic of my talk. And I will not talk about frailty, maybe in between a little bit, but I will mainly focus on quality of life. And I think Nikhil nicely showed that quality of life is important because there's such an improvement in the length of life of patients with multiple myeloma. And not only in the studies that Nikhil nicely showed, but also in real life, and that's exemplified by here Dutch data. These are real-world data showing that there's an increase in overall survival at 5 years from 28% in the year that I was born to 60% until 2021, and that will be even higher in the coming years. And also it's important to realize that that also accounts for the older patients with multiple myeloma. So not for the young patients, but also for the older patients, there's a sharp increase in the length of life. But we also know that it's not all about the length of life, but especially about the depth of life. And that was commented on by Ralph Waldo Emerson, and all wise men come from Boston. He came from Boston. So actually I had a slide here also of Nikhil. But Nikhil, in Boston, the quality of life is highest when you look in the USA. So for Boston, it will be approximately like Norway and the Netherlands, I think. Yes. So it's clear that quality of life for multiple myeloma patients is very important. But the question is what to measure actually. Do we know what we are measuring? Do we need to measure it in multiple myeloma patients? And do we measure it actually in multiple myeloma patients in general practice and in clinical studies? Now here first about what to measure, and I think there's several validated questionnaires, and you will probably be familiar with that. It's the ERTC questionnaires. The one that is used in general is the C30. It's a 30-item cancer-specific questionnaire, and it investigates functional scales, symptom scales, financial well-being, and global scales. And there's also one specifically developed for multiple myeloma on disease symptoms, the side effects of treatment, body image, and future perspectives. But it's also important to realize that whenever you send out these questionnaires, they only consider the past week. So every patient answers the question, how did you feel the last week? So whenever you send this questionnaire every 3 months, you will miss approximately 2.5 months. So it's important to realize when you look at those questionnaires. And the same accounts for the EQ5D. So that's the questionnaire that's used also to investigate the cost effectiveness, like Nikhil mentioned, the ICER, also being commented by Frederick. I think it's very important to implement this in all clinical studies in order to help to get access to all those novel drugs. But this is even about how do you feel today. It's also there's also a visual analog scale. I think that's very easy for patients, not only text, but also just to comment how you feel. But again, only the day. The other thing is, and that's actually coming from Denmark, from Leen Kongsgaard, and she investigated that there's real consensus missing about the difference, the definition of minimal important difference, because what you will find in all the studies is the statistical difference, but that's not important. It's all about the minimal important difference. And there are several definitions for that. The one of Quam is more strict than the one of Cox. Cox actually wants to have a grading scale ranging from small difference to large differences. And Cox also appreciates that small differences can be clinically meaningful, but I think we'll have to report both. I'm not a convincer of one or the other, but we have to report both in all the clinical studies. And I think the most important thing even is that we have to validate with patients whether it's clinically meaningful or not, because still it's a scale and using a cutoff, whereas patients can really appreciate that differently. Now, it's important to measure quality of life in multiple myeloma patients. Well, there's several publications around, and this is a cross-sectional example from the Netherlands showing that the quality of life in multiple myeloma is impaired as compared to an age and sex-matched normative population, and that accounts both for the function as well as for the symptoms. And in addition to that, it's not only as compared to the normal counterparts, so normal persons in the world, but also it's very heterogeneous within myeloma patients. So it's very important to measure that within clinical studies because it might be different for different subgroups. And then a little bit about frailty. And this from the GMEMA trial. They looked to the EOTC CQ30 and to the MI20. And what you can appreciate from this slide is that the frail patients are hampered in their function, and they report that more often than the patients who are intermediate fit. And also when you look to the specific complaints related to multiple myeloma or the treatment of multiple myeloma, it's clear that they have more disease symptoms and more side effects of treatment whenever they are frail. So it's important to look at subgroups when you investigate the quality of life in multiple myeloma patients. Well, this is in general, but when you look specifically to the patients, to the percentage of patients who are reporting either functional or symptoms, then you can appreciate from this slide that especially the frail patients do have impairments in physical function, they experience that, and also in emotional, role functioning, cognitive function, and also social functioning, and they have more complaints as depicted on the lower part of the slide. Now, it's important. It's heterogeneous, so we should measure it. We have validated questionnaires for that, but do we measure quality of life in clinical trials? And actually, we often don't investigate the quality of life in clinical trials. And I think it's important for our patients to know, but also for the regulatory agencies to have information about that there's an increase in quality of life whenever you treat your patient, because multiple myeloma give rise to lots of symptoms, and that's why progression-free survival is as important as overall survival. Now, what you can see here is that when you look to 283 studies that were identified, only in 118 of those trials there was planned to do quality of life analysis. And 165 did not even plan to do a quality of life analysis. Only 38 of those 180 studies a protocol was added. So they described in the statistical analysis plan what they would measure. Only 19 of those 38 did report what they actually stated they would report, and also often the quality of life analysis was not reported at all, or it was reported much later. So 40% of the quality of life analysis was only after 1 year, and so on and so on. So I think it's important from this to realize that we should not only increase the quality of life investigations in clinical trials, but we also should harmonize more so that we can compare the quality of life analysis of all the patients being included in clinical trials. Now, what is known about the quality of life of multiple myeloma patients who are now being treated within the clinical trials? And I was asked to tell about the non-transplant eligible patients. And I will first comment on the newly diagnosed multiple myeloma patients, and then I will move to the patients with refractory relapsed disease. Now, first about the newly diagnosed. Nikhil already showed, and you are aware of that, that when you look to the daratumumab trials, here daratumumab in combination with bortezomib, melphalan and prednisone versus bortezomib, melphalan and prednisone only, that not only the progression-free survival was superior, but also the overall survival. I think it's still important to read in those publications how many patients of the VMP-treated patients were treated subsequently with daratumumab. That was actually only 10% of the VMP patients, but still there was an overall survival benefit, which could be a little bit less when all those patients would have had daratumumab in second or third line. Now, when you look to the quality of life analysis, what you can see from this slide, I report here the general health status, the pain, the physical functioning, and the fatigue. Well, there is an increase over time when you look to general health status, to physical function, and you see a decrease in pain and in fatigue over time. But it's also important to realize from this slide that actually there was no difference between DARA VMP and VMP. There was only one significant difference, and it was at 3 months for the general health status. So you reach a better general health status with DARA VMP, so earlier. And the other thing which is important to realize from this slide, and which is not in the publication, I here show the cutoffs for the clinical, the minimal important difference, and for the fatigue, it's not above the minimal important difference. So patients still remained fatigued and not improving over time. Although they do have a better functional function, which is minimal important difference, they had clinically benefit with respect to pain and the general health status. So these were the whole group of patients. It's also, and here you can see that not all patients improve. So approximately 50% of the patients do improve, except for cognitive functioning. There are even less patients do improve. For nausea and vomiting, and for pain, more patients than 50% improve. But in general, 50%, and again, no difference between DARA VMP and VMP. Well, let's move on to DARA RD, because probably you are also able to prescribe DARA RD in first line. No, still not. I heard from Frederick that you're still waiting. But when it comes to quality of life, it may not be a problem. But when it comes to efficacy, of course, it is a problem. Because when you look here, when you look to the DARA VMP PFS of 35 months, here you see a median progression-free survival rate of 60 months. And also the overall survival is much better, which I will show on the next slide. All those patients had a median age of 73 years, so we're a real old population. And 15% of those patients had a high-risk cytogenetic profile, and a third of the patients had a high-stage ISS. So for all of these patients, a much longer median progression-free survival, which also translated in a longer overall survival. Again here, 21% of the patients who were treated with RD received DARA in second line, and 46% of the patients received DARA thereafter. And so more than 60% of the patients did receive daratumumab in second line, and still when giving it in first line, it translates in a better overall survival. So DARA RD in first line is important to have access to. But now quality of life. When you see here again depicted are the general health status and the pain. So general health status does improve over time, but not reaching clinical benefit. And also no difference between DARA RD and RD. Pain does decrease over time with both regimen, and that reaches the clinical significance. It's also important to realize from this slide that the compliance of quality of life questionnaires was more than 90% at baseline, but it decreased over time to approximately 80% through cycle 12. And I'll come to that back later. Does everyone benefit? Well, when you look at the patients who were in good shape, so with a performance status of 0, there was no change in general health status over time. Whereas there was an increase in general health status for those patients with a WHO performance status of 1 and 2. And that indicates that multiple myeloma give rise to complaints, and during treatment those complaints do improve, and therefore I think there is an increase in general health status. What about age? In both age groups there's an increase in general health status, again not clinically significant. And in the patients who were older, it develops later. So there's an improvement later over time as compared to the patients who are younger than 75. And that's important to realize, because still in the end, there is an improvement in the general health status. Now those curves are always shown in the manuscripts, but sometimes these tables are only in the supplementary files or even not mentioned. But I think what you can see is that indeed approximately 50% of the patients do improve with DARA-RD when it comes to many of the functional status and the symptoms, but there are also patients who worsen over time. So their functional status is decreasing and also they develop more symptoms. It's similar or comparable between both arms, but not for fatigue. That was better with DARA-RD, and not for cognitive functioning. That was worse actually with DARA-RD. Now, the conclusion in the paper in GCO was that DARA-RD compared with RD was associated with faster and sustained clinically meaningful improvements in patient-reported outcomes, including pain in transplant-ineligible patients with newly diagnosed multiple myeloma, regardless of age, baseline ECOG status, and I didn't show the depth of the treatment response. But actually, I would conclude that in general, there's no difference between DARA-RD and RD. In general, there is an increase in quality of life over time, but often not clinically meaningful. The improvement is independent of age and frailty. It is inferior at baseline. It shows slower improvement, but most domains remain inferior in follow-up, but they do increase, so do not withhold treatment in all the patients or patients who are frail, because we also showed that in our own HOVON trial that there really was an increase in quality of life that was clinically meaningful with daratumumab, ixazomib, and dexamethasone. And also it's important to realize that it not accounts for everyone. Half of the patients experience worsening over time. It might have to do, of course, with progression of the disease, although it was still unstudied, so formally not progression, but you see mainly at the end of the curves that there's a decrease in quality of life. And there's no increase in general health status quality in patients with a normal performance status at diagnosis. Now, what is known in relapsed refractory multiple myeloma? Well, Nikhil already showed that it's very crowded in relapsed refractory multiple myeloma. There are many regimens, so I won't go into detail for all regimens because then you will be here until 5 o'clock. But I was fortunate that recently there was a systematic review on all the quality of life analysis in those patients who were treated in relapsed refractory multiple myeloma. There were more than 10,000 patients, 19 randomized 19 clinical trials that were randomized, 9 non-randomized trials. The quality of life analysis were either secondary or exploratory endpoints. 20 studies. They published additional pro data after publication of the main findings, 40% after 1 year, 20% only after 2 years, 30% only reported the quality of life after 3 years, and 10% only reported quality of life after 5 years. Well, the validated questionnaires were in generally loose, so that was good, and I want to show 2 examples. Here you see the data of the POLLUX trial. So that was DARA-RD versus RD in relapsed refractory multiple myeloma. Patients were treated with more than 1 line of therapy, median 1. And again, you see that the general health status is increasing and that pain is decreasing. Important to realize, not reaching the minimal important difference, and actually no statistically difference between the arms. The reason why I showed it is when you look at the first line, which I just showed you, the MAIA trial, you can see that the effect of the quality of life in later lines of therapy is less as compared to the effect on the quality of life in first line of therapy. And when you look to the OPTIMISM trial, pomalidomide, bortezomib, dexamethasone, and bortezomib, dexamethasone, you see those patients were treated with 1 till 3 previous lines of therapy, median 2. There was an increase in response, there was an increase in progression-free survival when you look to PVD versus VD, but there was no effect actually on the quality of life. Now, Monica Engelhardt did look at the real-world data of almost 500 German patients, and she found that there was indeed a decrease in health-related quality of life over time. So when you look to later lines of therapy, the quality of life in general decreases. She also showed that there was an inferior general health status in those patients with grade 3 and 4 toxicity. So maybe it would be good to have a treatment-free interval. And actually, Nikhil already mentioned about the bispecific, answering the question of Frederick. And I think for quality of life, it might be important to try at least to implement a treatment-free interval, especially for the older patients who experience more toxicity, which might have an impact on their quality of life. So a difference between the frail and the non-frail patients. Now, is there any evidence that quality of life is increasing when you have a treatment-free interval? Well, there's only limited data on that. So again, the study of Monica Engelhardt in real-world life data, she showed that when you have a treatment-free interval, and I can't, maybe you see the pointer here? No. So when you look at the left column there, the treatment was ongoing. And on the column sides to that, you see the quality of life when the treatment was ended. And in general, you see that the quality of life was higher when there was a treatment-free interval, and that the complaints, so the symptom scales, were lower when you look to the treatment-free interval. And there's a very old, no, not very old, but there's an older study from 2013 also showing in real-world data, whenever you have your first-line therapy and then you have a treatment-free interval and then you start your second-line therapy, that the upper line reflects the treatment-free interval. And what you can appreciate from that slide, that quality of life in general is better. So in patients with relapsed refractory multiple myeloma, the improvement in quality of life is less pronounced than in newly diagnosed multiple myeloma patients. So give your best treatment in first line. You will win best from an efficacy point of view, but also from a quality of life point of view. The most consistent pattern when they looked at the review was that there's a maintenance in health-related quality of life, so it's not worsening over the course of the treatment without significant difference between the triplets and the doublets. And the improvement in progression-free survival and response does not always translate in a superior health-related quality of life, and there might be a role for a treatment-free interval. Now, I don't want to end very pessimistic, because I think with the novel agents, we can indeed increase quality of life and personalize the treatment. But we have to do something in order to show that. And I think the first thing we'll have to do is that we harmonize the definition of clinical benefit. And not only looking at a statistical point of view, which is clinically relevant, but involve the patients and ask the patients what they think is clinically relevant. And probably we'll need other scales in order to implement that in the clinical trials, but also in clinical practice. You see, when you do quality of life analysis in clinical trials, the compliance decreases over time. And the majority of data that are generated are on protocol, so the patients are in remission. So that might give rise to a bias, because only in patients in good condition might be compliant and not answering the question when they're feeling bad. So we need continuous myeloma lifetime measurements. We need digital tools and we need real-time monitoring, not ask how you feel the last week over the last 3 months, because that does not reflect the quality of life. So many of the things I showed might really not reflect how patients feel. There are also limited long-term treatment data. Often it's until cycle 12 or 16, not looking into detail in the maintenance phase. And in the maintenance phase, it might well be that after reaching disease control, the continuation of therapy might turn the pros into cons, because then the health-related quality of life might be hampered by side effects, whereas the disease is already under the control. So especially, I think, in older and frail patients, it will be interesting to look at the benefits of a treatment-free interval. And also here, in the clinical trials, we need continuous myeloma lifetime measurements and not only be reporting from one trial, but also look at the subsequent therapy, how the quality of life in those patients is. And I think it's very important to identify who will benefit. We do that in general when we look to efficacy. We try to identify who will benefit. And I think all the biological work we are doing, the site studies, the correlative studies we do with the clinical trials are very, very important, because then we will identify the patients who will have the most benefit of the treatment. But that also accounts, I think, for quality of life. Maybe a little bit less for the older patients than for younger patients, but there are many young people here in the room, and also for younger patients, I think quality of life is important. So we'll have to do subgroup analysis, look at disease-related factors, because when you have very high-risk disease, when you have more than 2 molecular abnormalities, you shouldn't aim for a treatment-free interval. Then you should aim for efficacy and probably are not able to stop the therapy in general for all patients. But when you're having low-risk disease, when you already have MRD-negative disease, then you can probably stop the therapy and have a better quality of life. So we should look at disease parameters. Are we allowed to discontinue the therapy? But also look at the patient-related factors such as age, frailty, and I think we need much more biological parameters to define those patients who will benefit from the therapy and can stand the therapy. It might be totally different from the novel immunotherapies. All the data I showed you here are really a little bit already the old-fashioned therapies, often even oral chemotherapy, using melphalan. I mean, that's a totally different toxicity profile and therefore also quality of life profile as compared to the novel therapies we're having now. We did a trial with in frail patients, as you are aware of, probably the HOVON 143 trial. The lenalidomide was much more difficult to deliver than the daratumumab, whereas in general practice, doctors say, well, we give a 2-drug regimen, we only give len. And I said, no, please give daratumumab, give a monoclonal antibody, because that's very feasible. It doesn't hamper quality of life. So that's very important to realize the novel immune therapies totally different. We'll have to do quality of life analysis in all clinical trials. Really, there should be no clinical trial without a quality of life analysis, and the report should be integrated in the main clinical report, or at least timely, so not 5 years after the original report. And I think it's not only in clinical trials. I know in the Nordic countries you have very beautiful registries, and I think quality of life should be part of that, because there are more frail patients in real life, their outcome is less, but also their quality of life can be different. Although again, in the HOVON 143 trial, there was a clinically significant increase in quality of life in the frail patients. And I think we should investigate the impact of a treatment-free interval, and we are aiming to do this in the coming months. We'll start this trial in the Netherlands. So we will discontinue the therapy after 12 cycles of DARA-RD in half of the patients, continue the therapy until progression in the other half of the patients, so an academic trial. And of course, we will measure quality of life during the first year every 4 weeks, and then thereafter every 3 months. And we should improve actually on that. I'm smiling. So here are the people at home I'm very dependent on. On top, Niels van der Donk, who's a hematologist with whom I work every day. Not today, but normally every day, and also the translational lab. So we're trying to identify biological and immune markers for therapy responses, but also for frailty. We do a lot of cost-effectiveness analysis in order to get global access to all of the novel drugs that Nikhil commented on. I think it's very important to do so. So we do some ICEs and try to get it into place. And the youngest doctors are investigating with me all the frailty. Well, thank you for your attention.
Thank you, Sonja, for an excellent talk. Yeah. Any questions for Sonja before we take a little break? Yes, Nina has a question.
I will just say that we did quality of life investigations in the high-dose treatment from the 19s, and we wrote about. We found that the thing that was important was the response.
Yeah.
Of the quality of life. So I think that's what we saw. When the response went up, the quality of life went up. And I think today we start often when people are perhaps have not so many problems. You have all those starting at, but they don't have any pain or something, and then they will not have that, I think.
Yeah.
So that's how it is.
Yeah, it's a very important remark. It's a balance between efficacy, of course, and toxicity, quality of life. So whenever you have complaints, of course, you will benefit and your quality of life will increase. At the moment, of course, at biochemical relapse, we already start to treat. And I think for young patients, really, that's very important in order to suppress the disease and get a long life. But we'll have to try, and with the immune therapies, maybe that's possible, to have treatment-free intervals, allow the T cells to recover also, and then start again and have a better quality of life and a better efficacy.
In that investigation, there was a treatment-free afterwards.
Yeah.
We measured the quality of life 2 years after the high-dose treatment, and there was down at the treatment, and then up and up and up, and when after 1 year, it was almost like normative.
Yeah.
So that because there was no other
maintenance.
No maintenance.
Yeah. Thank you. It's a very important remark. Yeah.
Just one small comment. As you mentioned, we're very good at registries here in the Nordics, especially. Not always was in them, but at least how it picks up every patient. So what the next step in Norway, where we have a very good oversight of all the cancer patients, and that means all. We are now starting this PROM project where they are automatically. I don't remember all the details because this is quite novel, but we are sending out quality of life questionnaires on an app or web-based, I'm not sure, but to all patients. And we take one disease after the other and starting this project. So in some years, probably, hopefully, we will have this sort of lifetime measurements of quality of life that is not related to individual drugs or studies and so on. So.
Then I'll come back and show the Nordic data. But I think it's beautiful to have that. Yeah.
Yeah, but that was a really beautiful presentation on very difficult topic. My question is, do you think frailty, the improvement in quality of life is different in frail patient versus non-frail patients? Because frail patients' quality of life is impacted by comorbidities and it could be myeloma related, but when they get treated, things change. So are those two groups to be considered separately and distinctly?
Exactly is happening what you mentioned, actually, Nikhil, because when you see at baseline, the quality of life, whether it's function or symptoms, is worse as compared to intermediate fit or the fit patients or just young multiple myeloma patients. But what you see is that their recovery of their increase in quality of life is sharper. There's an increase which is more pronounced as compared to the intermediate fit. We show that in the HOVON 123 trial, but also in the HOVON 143 trial. So you can win a lot. And especially, I think, with the immune therapy, and so you should not refrain only because patients are frail, because also their quality of life can really increase and become similar, sometimes almost similar to the ones who are intermediate fit. Not always, but sometimes, with respect to several of those scales.
I have one last question. The timing of the quality of life measurements is key. And what's done in many myeloma trials is to measure on day one in many cycles. And we know for lenalidomide, pomalidomide, and now for iberdomide, that if you measure after the pause week, that can give probably a different result than if you have done that on day 14. Yeah. Have you any thoughts on when you should do these quality of life measurements?
Yeah, preferentially you would do it every week. I mean, when you ask how you feel last week, and you think it's a reflection of 3 months, it's that we even report it is rather peculiar. But it's the only thing we do now. But I think when you're doing this, you should do every week. Now, you can't do, I think, the whole questionnaire every week. I mean, that's too burdensome for patients. But like a visual analog scale would be very easy for patients. So I think we should really move to handholds so that we have digital tools and that patients can answer only 1, 2, 3 questions. I mean, for us, I think the most important question is, are you happy 1 to 10 or 0 to 10 when you're very pessimistic? And then, I mean, that's the only thing maybe you'll have to ask.
I agree. Okay, thanks. Then we have a little pause of